I feel confident in how to score swallowing per this protocol, but I don't really understand how to apply this all to my treatment and diet recommendations. How do I target my therapy? How does this help me set goals?
That's a great question. And I think kind of regardless of whether or not you're using the MBSImP or a different protocol, the way you set goals and decide course of treatment is based on whatever impairment you're seeing. So with the MBSImP, looking through the components and how they work together to create a patient's swallow, it can tell you kind of this area needs to be targeted. And, with your clinical knowledge, you say, okay, these are the things I know are evidence-based to target that area, or strategies that could be used for this type of impairment.
And that brings up one thing to me that I think I used to see a lot, and I think still happens. But there are impairments that we don't treat. So again, the example of the person with a delayed swallow but is functional, they don't need treatment as long as they're doing fine, and so I have seen that, recommendations sometimes to have diet modifications, or I don't know what, for a swallow delay when it's not affecting their life at all.
So don't overtreat.
Don't overtreat. Yeah, we have to know how to interpret those scores.
Right. I'm taking a step back from the components at the end to see, what is the function of the swallow.
Right. But there's an education, just letting the patient know this is what your swallow looks like, right? So yeah.
And I think MBSImP in a way is somewhat prescriptive. It tells you which components need to be addressed. Then you go to the literature, you look at evidence-based practice, you apply principles of neuroplasticity, and you develop your goals based on those component impairments. And diet recommendations based on that as well, in combination with, penetration, aspiration, and residue and the outcomes. But I think it's somewhat prescriptive. And a little plug here, we do have the companion MBSImP treatment course, which takes you component by component, walks you through the literature, and gives you maneuvers, strategies, exercise, programmatic exercise that are meant to target the specific components on the MBSImP.
Yeah, the individual components and groups of components, I would say, inform your therapy selection based on the evidence that's in the literature and best practice. You can't wait for every clinical trial, right? We talk a lot about clinical trials, but not today. You use best evidence, best practice. And so, for example, if you have a patient who has decreased tongue base retraction, unilateral pharyngeal paresis, and a reduction in PES opening, say a 2, pharyngeal contraction is a 2, and tongue base is a 3, well, then I might use a combination of reducing consistency of the bolus, at least initially, turning the head to the impaired side, and implementing an effortful swallow to engage all of those components. So you build your program, you use compensation and you use adaptation in the beginning, and then you gradually do new learning and new skill and anyway. So yeah, I mean, it really does help guide your treatment.
And yeah, not to interrupt, but with that example that you gave, Dr. Martin-Harris, and another thing, especially for a newer clinician or someone who isn't using or completing studies as often, it's really hard to make those decisions online and to sometimes to ask the patient to do a head turn. Sometimes you don't realize it, and then you go back and analyze it and you see what the problem is. You can still treat that even though you weren't able to necessarily use that modification during the study if you weren't able to think on your feet, which can happen a lot, especially when you're not as familiar. And so the protocol still helps you make that decision.
And during the course of treatment, if you're not sure, you can always, and you're just looking at the impact of a treatment, like something like residue, the amount of residue, you can put a scope in a patient's nose and look and as feedback and have them do a swallow and squeeze and see if it's effective. You don't have to bring them to fluoro again.
Right.
So yeah, absolutely. The other thing that this reminds me of, it kind of combines these questions. people always bring up mixed consistency. If I don't give mixed consistency, how do I know? And what the analogy I would give, or the example I would give, is if you have delayed initiation, take it back. If you have a score of 2 or 3 for bolus hold, you're having difficulty containing a bolus in the oral cavity, and you have a score of 3 on initiation pharyngeal swallow, you clearly are going to have trouble with chicken soup, because you can't do 2 consistencies at one time. So it's just that helps inform my treatment, just putting those things together. The consistency with the actual impairment, that really informs not only my therapy, but diet recommendations. So yeah.